care delivery in the schools. I'll get to that in 1 minute. I want to point out there may be something that, for measurable success, may be easier to get a handle on than something new, and that is chronic disease management and cost avoidance based on complexity of illness and transport. Specifically, if one were to look at healthcare, two of the major problems that we might see in rural Arizona, and particularly on the reservations, would be congestive heart failure and renal or pre-renal failure. And that's usually tied to diabetes in some way, so it ties into a larger project. Those numbers should be, and so in both of those cases, you're dealing with a patient who has relatively high dollar amounts for admit, readmit, that could be addressed by care providers provided in an urban setting that would hopefully act as a nurse manager, nurse mentor for a subset of patients that could be addressed. And there would be clear metrics in terms of the complexity of illness, utilization of services, and transport from rural Arizona to urban Arizona that Access probably already knows. Somebody at Access probably could tell you, based on zip code or based on region, what they're currently spending for particular diagnostic codes, specifically CHF and renal failure and management of those in terms of transport and utilization. Does that make sense to everybody?
Alan, this is Galen. Yeah. There was some pretty good studies done that might be able to be translated into this type of forum out of Tennessee and out of a couple of other places that had to do with behavioral health. And the studies that they showed with the behavioral health as telecommunications or as distance servicing was provided through the broadband transport, the savings were considerable. They showed savings of hundreds of thousands of dollars in just a very small group of people.
Please stand by while your recording connection is established.
I lost you, Galen.
Say again?
You lost you.
I just lost you there for a second. Okay. So, and by the way, telepsychiatry,
This conference is being recorded.
Telepsychiatry, behavioral health, I think, is a reasonable area to pursue. I asked a friend of mine, Dr. Sisley, I don't know if she joined us or not. She's probably one of the foremost providers of telepsychiatry and behavioral health to join this call. Her entire practice in psychiatry is via telemedicine. She no longer sees brick and mortar patients.
Wow.
And she is someone in the States.
And my point was this, that the same costs that are saved or avoided by patients and by practitioners both can be, in fact, you can track it even in different disciplines and modalities, because it's the same people. I mean, you travel to Phoenix for one particular problem to see a psychiatrist, and you travel again to see an eye doctor or your phrenologist or something.
Alan, this is Ralph. Arizona has a pretty good track record on mental health. NARBA has done over 10,000 consults here in the state of Arizona dealing with psychiatry. So we can get a good source of information from NARBA.
I think what I'm hearing from Mike is that we want some clear baseline metrics on a particular community that's underserved in terms of broadband, and then we want the application of services to that community to show an improved outcome in the near term.
Yes, what the services are that are affected are costing today without the broadband telemedicine capability, and then what happens to those costs, and the benefit, and also the improved benefits of care that happen when the telemedicine is invoked. I think that's an important strategic thing to show the rest of the world about the value of this. The hissing just came back.
Terrible.
Someone who just unmuted is got a phone.
Hello, this is Janet Major. Can you hear me?
We can, but there's a lot of hiss in the background, Janet.
What is this? Can you hear me?
Lots static, Danny.
Am I the static person?
Yeah, you need to mute your phone, Janet.
Yeah, I think you are the static person. She wants to talk, though. Go ahead and ask what you want to ask, and then mute, please.
Well, I apologize. I don't have a different phone. Can you hear me?
We can hear you over the noise, yes.
Well, one of the points that I would like to make is when we look at choosing a pilot, I think it would be important to choose something that we know the billable aspect of it has been resolved, because it's important that if we do want to quantify success, success is quantified in numbers, not only in terms of money, but the number of patients that can be seen. So I think about groundwork that's already been laid, and the pilot project that we did with diabetes patients in Amato that was a wireless project. And we wanted to continue our work with diabetes that we had done with Carondelet and St. Elizabeth of Hungary Clinic, but the fact is we put out an RFP for a provider and nobody answered. So if we looked at a community like Amato and an application like teleophthalmology and retinal screening, I think that we would be able to collect the data that we would want to communicate success when we are serving a very poor community and communities around it that otherwise would have no connectivity.
One of the things, Dr. Pitt, that you had...
When you say retinal screening, Janet, what do you have in mind?
The non-Midriatic camera that we've used successfully to do both screening for diabetic retinopathy and glaucoma. And the added bonus is it's a billable expense. The thing that really helps quantify it as well is we might not be able to count airbags, but the real true numbers are that people who live in Amato can go to the food bank where they get their food and get diabetes services, including getting screened. And these are people who otherwise wouldn't have that service because they sure wouldn't put gas in the truck to drive to Tucson to get the same process done. If it's done in their community because there's connectivity, well then we're going to increase the number of people who we would be able to screen and therefore do follow-up and improve the battle against diabetes. So,
do you have practitioners who are willing to do the retinal screen?
Pardon me?
Do you have practitioners willing to do the retinal screen?
Well, it's a service that's currently offered by University Physicians Ophthalmology at the Tucson Prison, and it's also a service that's been offered by Carondelet in several different communities, too. There are several cameras throughout the state.
Alan, in prior...
All right, we actually did some testing recently on a new slit lamp, which basically we can convert the majority of slit lamps to simple laptops. To allow for transition in real time of slit lamp exams, or retinal exams.
Alan, let me interject.
And that's great because that's billable.
Alan,
it needs to be an application where the billing processes are already in place, or we're not going to get the numbers, in my opinion.
Let me interject.
And do you have baseline numbers for the savings on that done in other communities?
I'm sure we do, because we publish reports for the advice grant. Either Donna Z or Dr. Emery Lopez could get you those numbers.
I know Donna well.
Both of you, can I interject a thought here? Alan, in prior discussions, you have talked about how important it is to also provide a demonstration that payers are willing to buy into actually paying for these services on insurance plans, and that you have some connections that you think might work. Can we add...
I'm having tremendous trouble hearing you, Janet. I don't know if it's your phone, but would you mind trying to start to see if it is?
Yes, it was. So the thought is that I think should just get added to this discussion is something, Dr. Pitt, that you and I have talked about previously, which is the importance of bringing payers into the equation too. I think a major demonstration of success will be having an insurance company being willing to pick up the tab, for some of this kind of care.
Ralph has experience with this.
Yeah. So and Ralph Garish has some thoughts, I think, about the same thing.
Well, one of the questions that I have, we've done Amato. We know Amato works. I think what we want to do is go to a new community that we have no experience whatsoever, and look at the cost before and after.
Clean baseline.
Clean baseline,
right.
And we can compare it to Amato. and find out the results. And of course, Amata is very close to Tucson, so the travel distance is not going to be as great as if you're taking some remote community like Winslow having to come to Phoenix or Tucson. So I think we have to have a community along, of course, the Trenchway too, and that's what we want.
Yeah, it has to be along the Trenchway, within like 20 miles of the Trenchway.
Yeah, what we did with ATIC is we put in a wireless system, and between Tucson and Nogales, and we were able to link first responders as they were moving. We were able to transmit information at 90.
Not while they were moving very fast, 30 miles an hour.
90.
No, 30.
30. Okay.
Okay.
Anyway.
It's a slow ambulance.
As part of the off link, since Amata was along that route, ATIC linked Amata to the University Medical Center.
Right. Well, Janet, I apologize for cutting you both off, but I just thought that additional thought ought to be part of the conversation. So if you can go back to what you
I had pointed to Ralph because we actually had meetings that I attended, and I can't remember which insurance company it was, where we actually were creating the opportunity for the insurance as a payer to provide the service and to in fact accept the bills that are sent.
United, I think it was United Health.
No, it wasn't. What's the other? Start to see. What's it called?
Sigma?
Sigma.
Sigma. Oh yeah.
Sigma.
Yeah, Sigma. We approached Sigma because they had a capitated patient base. And we were going to take a look at what their costs were on the capitation, and then with telemedicine follow-up, especially on looking at hospitals to keep people from returning. So that's another area that we can look at from cost. Look for a capitated medical community and then compare it before and after.
Alan, you've been in some conversations with payers, have you not? Can you share that maybe with the group?
Well, I've started conversations with Access, and I think there are billable events. In no way do I consider myself an expert in what is paid for and what is not paid for in telemedicine. And Donna Zorsky actually may be more of an expert because she has a very active program down there at Carondelet. I think it is imperative that rather than try to cause a change in what's reimbursed, we leverage what's existing with hopes of expanding services.
In the time frame.
One of the things that I'm starting to understand is that the vision of what telemedicine is for many of the medical directors at Access who set the bar is really not what telemedicine or collaborative care could be today. So for them, telemedicine or collaborative care is something over there. It's something for a limited opportunity for rural America, rural Arizona. It is not really for urban, which I kind of find as a mistake. Ultimately, I believe that it's both an urban and rural because geography doesn't necessarily have to be distance. It can be just the ability to travel. In other words, an indigent person may not be able to get on a bus to get to where they need to be. And certainly the time that one takes to sit in a physician's office or a care provider's office may overwhelm the system. And so that vision is somewhat limited. And I'm struggling a little bit in terms of the real drivers of this win, and the people who own the data are not here to be in the discussion.
How do we get them in the discussion?
Well, I am hoping that you and Aaron and others have leverage to bring Mark Lieb in, to bring others from Access in, and say, what could we fix for you? Let's presume that we can figure out a business model that makes sense to incentivize Cox or LTE to be deployed in an area that currently doesn't have broadband. We would work to do that where someone who does not have broadband today has it. Can you give us a zip code and a disease that you're struggling with, that you really have a problem with, that we can fix for you?
I like that, a zip code and a disease. By the way, we just came back from a meeting with Cox, and they are enthusiastic supporters to our surprise of this plan. and they are interested in participating in figuring out how to help with the pilot program as well, including, I think, they haven't promised this, in concrete terms yet, but in fact, being an early participant in lighting up the conduit, if you will, in a rural community where they don't currently provide service. And I think CenturyLink will come along the same way based on other conversations with them too. So,
I've been very encouraged. I had some conversations with Chaim, and I think it's in everyone's interest. My vision of the future is that your healthcare is delivered over your cox box.
Right. Hyman, did I quote that properly, I hope?
Yeah, no, I think you accurately reflected in a whole series of ways we're excited about the possibilities of this and using the technology and the connectivity into people's homes or into doctors' offices to kind of broaden the ability in the state for all sorts of these services.
Terrific, thanks.
So, yeah, very much on board.
Mike?
Mike, irregardless of the disease and area we pick, I think there are 3 levels that we might consider for the pilot that might be kept in mind, just from a pragmatic point of view. The first one is, the lowest bar is provider to provider. I'm a nurse or I'm a general practitioner, and I need help managing the complexity of disease, and I reach out to a specialist who is somewhere else.
Right.
In that world, you have an electronic medical record that can be leveraged to look at outcomes and care around that patient.
Right.
Things get pretty, that's not that difficult. The next layer up would be provider to patient in a limited sense. In that world, I would choose patients who have some high dollar amount tied to them.
So expensive diseases, basically.
Expensive diseases, right. The CHF patient that I mentioned, who's in and out of hospital, the renal failure patients or pre-renal patients, those would be obvious ones to get outcomes again. And then the most difficult one is going to be kind of ubiquitous telehealth for wellness and things of that nature. That's probably not going to be appropriate for the pilot, in that you're going to have a large number of patients before you have meaningful metrics to show value. And I think ultimately that's where we want to be, but in terms of showing a meaningful outcome, it's going to be difficult.
Yeah, and that's a distinction between the pilot and a real rollout, I think, too.
But I'm hoping that this group, when they formulate the vision for the governor about what broadband can bring, lays out those 3 levels: provider to provider, provider to limited patients, expensive dollar patients, provider to patient anywhere. And they not only say, we're going to do this today, but we hope and expect your support moving forward for these other 2 layers.
Yeah, if we could just find someone in the governor's family who is ill that we could take care of this.
Yeah, let me make a comment here.
Okay, Galen has a comment.
All right. One of the biggest problems we have is defining the funding stream, obviously. And we were presented with an idea yesterday at the governor's office of somehow leveraging into a credit, upfront credit and cash flow against a stream of payoff of that credit later on. And that was the idea that was presented to us, so it's kind of self-funding. One of the issues that we always have as we try to bring transport into the picture is that everybody thinks that it's free because they think the internet is free. And I think that maybe what we have to do, and the idea also came to me about this, that what you need to do is set up a contractor who is promised a cut of the gain share, if you will. And then you have this gain share be part of the process so that the entire savings is not consumed either back to the provider of the payer, or back to the provider as savings, or back to the patient as savings. But so there's a happy medium somewhere, and there's a gain share that is established by agreement in advance.
What kind of contractor would this be?
It could be somebody who is, in fact, skilled at making the transport work and also going out and getting the contract started. But you can't give up all of the gain share in any of those other directions, or you have nothing that you can continue with.
Several years ago, David and I went to the HIMSS conference in Florida. While at that conference, I had a meeting with the telemedicine people of AT&T. And one of the things that I proposed to them is, because the equipment used for monitoring telehealth is a one-time type thing, but rather expensive, that AT&T, since they're in the communications business, put forth something like the old Princess phones, where you rented them, and only for the time period that you needed. They could use the equipment then as a capital write-off, but the patient or insurance company would only have to pay for the rental for the period of time that the patient is being monitored in the equipment stage. They toyed with it, but never came back to me on it.
Well, that brings up another detail too, Alan, in the kinds of stuff that you and Janet are proposing. There's another aspect of this. In this pilot, do we try to actually do telehealth to patients in their homes, or do we instead do it at locations within the target community, such as the schools or the library or some other kind of?
His first phase was doctor to doctor.
Yeah, well, in doctor to doctor, yeah, you've got to do it between doctors' offices.
I think that the time course kind of merits that you make it on institutional, so care provider things, as opposed to, I think if you try to go to home, you're not going to get anything done in a timely fashion.
I agree.
I mean,
yeah.
Jaime, you can answer that one. If you think you want to deploy a bunch of broadband into some of these homes and set people up, but I think in a time span, it's not going to happen.
Well, how would
I mean, ideally, you'd look at people who might already have broadband services. So it's less about how do you get the last mile taken care of than do all of the pieces come together to serve the patient well, to get the doctors compensated, and then we can say, okay, we've got a model that we know that we can implement and work, and now let's figure out how do we solve the broadband piece of it separately.
And that's the integrated contractor that I'm talking about that needs to be involved in this with a profit motive, because they get part of the gain share.
Yeah, I guess to your point, Galen, what I would wonder about is if we went to a broadband provider and said, we understand that there's a fairly high bar for you to provide broadband to a community. If you went in first to help solve a healthcare issue, we would give you some advantage in terms of exclusivity or jump on that marketplace. And you would begin to, and that would erode as you began to sign up additional customers in that geography. So my assumption is, let's just say that I'm just fictitiously making this up. We chose a project of a high-risk patient population, and we said we want to deploy something that will serve 300 patients at risk, and we know that the return on investment for the broadband provider isn't there based on 300 patients. But our assumption is that as that is available, they are over time going to get customers who want to use that broadband for other purposes.
Yeah, I mean, this is something we're going to have to model out, because it's not like the 300 patients are likely to be in close proximity of each other. You're going to have a density issue that is potentially going to drive the costs way out of whack. So that's why I say, I mean, I think you're going to have to prove and solve some of these pieces separately, because the delivery of broadband is not a technical issue. It's totally an economic question.
Return on investment issue.
Absolutely true. Yeah,
right.
It's a return on investment issue. Exactly.
Right.
Yeah.
Whereas the rest of these pieces, I think, need to kind of be proven on a scalable sort of way to drive success.
And one of the issues in Arizona that we're going to find is that by hook or by crook in the last 10 years, almost every one of our communities has been outfitted with some modicum of broadband. The densities inside those cities are pretty low sometimes, and sometimes the speeds are very, very slow. Sometimes the backhaul taking that is provided to cover the last mile is also pretty weak. But we're going to find we're not going to find any cities that or towns or communities that say, do you not have broadband? And everybody's going to say yes, except it's only in the center of those, and the communities, as you radiate out from the center or from the CO there or the whatever's there, you're going to find that the densities get smaller and smaller, and there's also typically no choice as to a provider. And so and one of the concerns that I had as I offered this idea of this, shall we say, contractor, integrator contractor, is that the provider typically is going to be different in every case. In a small environment, there's only going to be one or two of them. And so you have another problem of almost having to criticize the provider for the lack of density in a particular area. And,
Galen, by the way, I'd like to make a point. So it's really interesting. One of the problems with telehealth has been actually both sides of the equation. So let's take for a minute that I'm going to solve Hein's problem by simply providing broadband to a limited number of locations in rural Arizona. I'm going to go up to the reservation, and I'm going to convert the schools into clinics by putting broadband in. And there's going to be a multitude of wins there. One is health, other is education. But I'm going to convert the school into a place that I can do care. Okay, so that's awesome. I do that. I have 5 locations instead of 50 that are disparately identified.
That's a pretty good model, I think.
Okay, so here's the other problem is on the back side of that, the care providers today currently have to walk into a single location to meet those patients who are at the schools. If you go to me in my practice and you say, Alan, there's a point-to-point connection at T-Health downtown, and you have to walk into that booth to see these patients, I'm not going to participate. I'm not going to do it because I'm in the middle of a clinic and you're asking me to see a couple of patients a day. There's no way I'm going to do that. So both sides of that equation have to be considered for the healthcare transaction to occur.
Yeah, Alan, this is Hyman. I agree. That what you've got to take into consideration, though, is that often the economics are slightly more attractive for the provider than they are for the person receiving the healthcare services. So for the provider, they very often now need to be connected to the hospital groups that they're part of. In many cases, they're going to be moving along a platform of electronic medical records that if they look at this intelligently, that they're going to want to have some storage off-site in a secure environment for business continuity purposes, and on and on and on. So there's going to be a certain amount of need that's going to drive connectivity to most of the providers. And now it's a question of how do you get it to the consumers on the other end? And I keep reflecting on the conversation that we've had, and I don't want to land yet, but I think it drives me more to kind of an open IP environment rather than a proprietary television-based service.
Well, another point, though, Hyman, to Alan's point, is that the providers don't have to be in that rural community. They can be well connected on portable and permanent devices in their working space in urban areas where there's lots of bandwidth.
Yeah, that's my point, because I thought I heard Alan saying, well, we still have to solve for the providers, but
You do. I swear. Yeah.
But the economics for the providers are there are more things that are compelling them to have a broadband connection.
I would have to disagree with you. And here's why. The providers have a patient waiting room that is absolutely full. They don't want to move 100 feet, let alone a half mile, to walk into a booth.
But why can't they connect to the rural community on whatever devices they're using in the clinic that they're working in?
But there's, I mean, Polycom actually has some.
But that is not in the historical context of telehealth.
Well, but isn't that a context we can change?
Wait, but that's, you know what? Polycom actually has software that's under $100 that is something similar to like Skype, but for healthcare. So, I mean, there is products out there that are, you know, more current and more up to date than just a big bulky type.
Yeah. So Alan,
I'm sorry, I'm Jana Cooley.
I'm saying it needs to be considered in whatever plan we come forward with. Is that a presumption has to be that and there is no compelling reason currently for most providers to participate in telehealth.
But if they don't have to leave their office and
then
can,
they'll participate. But
okay.
That has not been traditionally what we've offered.
But what's the barrier? Is there a barrier for having them do this work from their office? I don't know.
No, I don't believe there is. I think we can come up with solutions that do that where they don't leave their office. I completely agree with that, Mike. I'm just, for the group, I'm just phrasing this because, first of all, there is not a compelling business case for providers to participate in telehealth.
Yeah, so Alan, I don't disagree, and this time, and I'll be of limited value to helping solve that part of it. My point was that the economics of bringing broadband to providers is fairly easy to resolve. Most of them have compelling needs, regardless of whether they participate in telehealth or not.
I don't see broadband as an issue for the providers. Most providers
have
enough bandwidth in the workplace that they could participate in these transactions if they're left to do it in their workplace.
Right. Yeah. So then I get your point of if I've got a full waiting room and particularly if I'm have stopped accepting new patients, what's going to drive me to take patients remotely? Then that's a whole different question.
Yeah, and that's, to me, the biggest struggle we have with the introduction of telehealth is why should I care? Why should I be engaged? It has to be, from a business point of view, I have to be able to make as much or more doing telehealth as I can in my clinic practice. Yep. And if you can't come up with a compelling case in that way, you're going to have difficulty. I guess it was Janet Major who said, we had this RFP, I couldn't even get providers to participate. And I completely understand that. Most providers feel overwhelmed already. They're not looking for new business. As we all know, their offices are closed. Can't even schedule.
Right. So clearly, this should be clearly from the provider's perspective. This should be a straightforward software application that runs on existing devices that they probably already have, and all they have to do is not see the next patient from the waiting room, but turn to the screen and connect to a waiting patient in one of these remote communities, and then expect to get paid for that at the same levels that they would as if they had seen the patient in their.
The solution has to consider the revenue stream for the provider if you want to scale.
Right, and I agree completely. I mean, is there anyone who disagrees with that?
I would ask one thing. Sure. Is anybody looking at it from the other end for people that are receiving maybe no care? What it might give to them. It could have nothing to do with monetary issues. It could just be access. Providing access would be a game changer for them, even if it cost money to somebody else. I don't know if that's a consideration because this is really out of my area.
Yeah.
Give me an example that's scalable.
An example that's scalable. I'm not thinking
I
of
get
it
what you're saying. I might volunteer my time on a Saturday afternoon and go work at a free clinic, but I'm not going to do it over and over and over again.
Yeah,
except on a Saturday afternoon.
No, that's an exception. We're trying to make exceptions in the rules, and that just doesn't happen.
No. I'm not sure it's necessarily just indigent care, or if you're in the middle of nowhere and you have to travel 5 hours to get to care, is what I heard you say.
That's what I'm referring to.
You might be very wealthy,
situations
but
like
you
that.
just can't get it.
Well, you've
So we're
also
getting
got
no-
access, which would
But
pay
that's
for
the
some.
patient side, not the provider side.
Access.
Right. Yeah, so if the patient has the means to pay either through insurance or personally for a physician to see them, it's a lot easier if there's a way to do that and they're 500 miles away physically from seeing a physician to get on a screen and get help that way.
But this goes back to having the fee scale that supports
Right.
being paid for remote
But
treatment.
that all requires either an insurer who's willing to pay or a patient who's willing to pay in that environment to get that care. Because Alan's point is basically the doctors won't, except for charity work, won't do this routinely without some kind of compensation. So. And not just some kind of compensation, actually, to be more precise, compensation that is on par with what they collect when they deal with patients physically.
That's correct.
So what we have in the rural areas is really an accessibility problem as opposed to maybe a wealth problem. And I think that's the true case, because if you read the reports that the behavioral health solution provided, or the benefits that provided, the cost savings were dramatic in the non-medical areas. The cost of travel, the cost of taking kids out of schools, all of those types of things have to do with accessibility as opposed to medical care.
As opposed to the ability to actually pay for the care
But
itself.
to Alan's point, that's about accessibility.
Accessibility.
And that's all patient or payer side. It is not on the.
But there is a high cost of recidivism of patients being discharged from the hospital, not following what they've been told to do, and no monitoring, and therefore they come back in sometimes in worse shape than when they went out. Mm-hmm. So there is a medical benefit.
Ralph, that's not on the currently. That's not on the provider. You have to.
It's on the payer.
The provider is. I mean, they care, but they don't care.
No, but the hospitals are going to. The CMS is going to start penalizing the hospitals.
Well, that's different. That's what's going to happen, not what does happen.
Yeah.
Okay.
And so,
ACOs can
again,
change
we're looking at a pilot where you want providers to participate. You're going to have to come up with something that they go, I want to do this because, and they can see a very transparent reason why it's the right thing to do, and from a revenue point of view, it also makes sense.
So to summarize what I've heard so far, is that the payers need to be able to provide their service from wherever they are. And that's probably fairly straightforward from the standpoint of connectivity and devices that they would need to use. The patients in the remote community need to probably come to a single point of service dispensing, like a school, at least in the initial pilot. Now, that can be broadened out.
And the reason for that is quality control.
Well, quality control and also accessibility, and frankly, there's a secondary one too, which Alan passed over, which is it's the combination of the benefits to get that connectivity into the school for educational reasons, and then to also use it for healthcare reasons. So there's kind of a double bang there.
No, I think there's a lot of value in doing that.
Yeah. And then we need to get hopefully a payer who, at least on a demonstration basis, would pay for those chronic care services for children and parents who have the need at the school to be served by remote physicians who are agreeing to be the providers.
Do you know that schools in rural Arizona, or do you have an area of rural Arizona where schools are underserved in terms of broadband?
Oh, just about every rural school there is out there needs a nurse practitioner.
Yep.
And in fact, telemedicine ran a program 5 years ago at Emerson School in downtown Phoenix. And it was a really, really successful program because that nurse did not have to cover the entire Phoenix Elementary School District. They just set up shop at the former nurses station inside Emerson School that I used as a kid, and they were able to, in fact, do a lot of examination of students at that school.
Mark Masterson said basically all of the rural schools are either totally unserved with bandwidth or have very limited bandwidth, insufficient.
Okay.
Insufficient.
So one is the provider, it's the school nurse, and the other is the bandwidth. So you're telling me that you have needs that could be met for broadband deployment in school.
Yeah.
It's a very compassionate thing.
It's,
It would solve the education issue for a certain pilot. They could run on that same bandwidth some of their own pilots in terms of education.
Yeah.
And then it's an issue of healthcare infrastructure that could be layered on that school that would enable that to allow the community to use that center as something of interest.
Yes, I think that's very powerful. And to Galen's point too, it's not just doctors who need to be the providers. It's nurse practitioners in many cases for a lot of these chronic issues, I would suspect. Am I accurate in that, Helen?
I'm sorry, say that one more time?
Well, it's not just the physicians who need to be the provider base for a demonstration like this. It's also nurse practitioners. A lot of these chronic cases that I assume would be being seen remotely, don't rise to the level of needing, physician intervention,
there's no doubt. I mean, my personal belief is that you want to not engage the specialist unless the patient has been already screened by a lower level practitioner.
Yeah.
So you want to leverage what I call the healthcare pyramid, where you're bringing on in higher and higher levels of specialization on an as-needed basis, which actually allows you to best use your assets. You really don't want your super subspecialist, your surgeon, your retina, or your retinal specialist, to see everybody. You just want to have the surgeon see the people they're going to operate on,
right?
Because they've already been pre-screened.
Right.
And the retinal specialist pretty much already knows that the next patient is going to need his service.
Yep. I agree, and that would then allow that remote school to be tied into the kind of network that you've shown me of specialists and so that the patient can
we could definitely build a community around a healthcare community around the problem. We could definitely do that.
Right, and so as the medical problems escalate for a particular patient at that school, you can actually keep connecting them to different levels of people in that network as necessary. Is that a fair statement?
Yeah. For those of you, I work a lot on what I call clouds and crowds, leveraging browsers and communities of providers so that the right provider is brought to the point of service over any device. And so we could definitely do that. I think critical for this is keeping the scope limited so that you have a defined community rather than you're trying to drink the ocean.
And I also think at a technical level, this, and you've talked about this before too, it all should be browser-based, so it works on any device at the level of intervention.
Except for the camera, it has to be high definition.
Well,
in most cases, except
for the pilot, do we really need to go to that?
I come from the PACS world, okay? The historical context of the PACS world is that for many years in the radiology community, there was a debate about how many pixels had to be on your screen to appropriately interpret a radiology image. And finally, you no longer hear that debate.
Sure.
And the reality is that it has to be good enough that the provider feels comfortable that they're able to adequately assess that patient. That's it.
And most modern screens already have very high pixel counts. I mean, off the shelf.
That's true. But what people have to realize is to say quote-unquote high definition or really expensive cameras means you get very limiting on one side of the equation or the other. And it's very difficult to scale and have ubiquitous solutions if the technical requirements become encumbering.
And down the road, in a full-scale implementation, there could be, regional centers in the middle of numerous rural communities where someone could drive for that kind of remote healthcare without having to go all the way to Tucson or Phoenix.
It depends on what the use case is. I mean, if I'm a renal patient, I may have to see you, but I don't have to see you perfectly. If I got to see your retina, I may need a very high-quality image to decide what to do next.
But you hit it on the head. The use case for the pilot is going to be necessarily limited. You're not going to take everybody that walks in the door.
Right. Well, I'm glad I raised that point because it got shot down and we just learned something. But we don't need the high quality. We can get
except in very special instances.
It's
right.
okay.
I think it depends on the use case, and it has to be good enough you rely on the provider who says, this is good enough that I'm able to engage and care for this person.
Right. Or you need to drive to a hospital where there is such a camera or something like that, right?
Well, that's always the case. So forget the camera for a second. Just imagine you're a provider and you're meeting someone in a telehealth transaction and you can't touch them, right?
Mm-hmm.
You as a provider have to make a judgment whether you have enough information via the telehealth encounter to safely care for that patient.
Mm-hmm.
And if you don't, you basically have to turn to the patient and you have to say, based on what I've heard from you and what I can see on the video, you need someone to actually do a physical exam on you, and you need to go to the nearest urgent care, the nearest ED.
Mm-hmm.
I can't continue to care for you for this particular event. That will always be the case.
Yeah.
Right, and that's going to be a step forward from where we are today, right? I mean, today we got nothing. And what we're going to find is a portion of patients who this solution will address more effectively and economically, and a portion of patients that say, okay, I know enough that I need to move you forward to a higher level of health care. And, I mean, either way, we're better off.
Oh, there's no doubt. And I would also mention, by the way, that patient compliance with a particular treatment plan is one of the major obstacles to effective care. And compliance is directly related to the relationship a patient has with their provider. This is very clear in the diabetes literature. If you require someone to keep their appointment with their diabetic educator, and they have to drive 3 or 4 hours, you can bet your bottom line that they're not going to do it very often.
Right.
But if you provide that educator with some frequency over easy modalities, I think you're going to improve care.
Yeah, if they drive 10 minutes to their school to keep the appointment, and
they drop off their kids at school, for God's sake, and they walk into the other room that's there.
Right.
And boom, they're done. By the way, there is something that I honestly believe may have play here. I'm aware of another provider in the state who builds transportable businesses. You basically can pack up a business and set up what looks like a full business in minutes on the back of a truck.
That was a dentist that we saw at telemedicine a few years, a couple quarters ago.
This is a new thing. BizBox for You, I think it's called. This guy, I saw this guy and I tried to invite him to APIC because I see it as an opportunity to have mobile clinics that is something beyond a van. And this might be part of that ecosystem.
yeah, I bought a bunch of stuff off the back of that truck, and it didn't work very well.
I have a question. I have a question that makes this, shall we say, this room distinctive, maybe at a nurse's office or at a school nurse's office, which has now been turned into a closet because there's no nurses there anymore. Are there any other telemetric type devices besides a camera that might be needed that would make this a would you need to be able to monitor a blood pressure or blood
oxygen
Depends
levels?
on the use case. It absolutely depends on the use case.
But there's some simple sensors and devices that would telemeter very readily, and that might be just a standard kit bag of equipment that goes into the school.
I agree with that. Right. What is in that room will be determined by the use case. But clearly there are some standard devices or standard things you'd want to have engaged in that transaction.
Yeah, I know that every time I see the doctor, they always weigh me. I always hate it.
There's basic equipment on USB ports.
What was that?
There's basic equipment
I
on
like
USB
the
ports
retinal
today.
use case and the diabetic screen particularly. So I think I'd like to go back to the question of what's the problem that Access would like to solve to identify a location that might give us some direction.
So you're talking Access as the payer, or you're talking Access as availability?
I'm talking Access as the payer.
Okay.
Ultimately, if you can get Access to say, I have a lot of difficulty in that I know that I'm spending a bunch of money on this particular problem in this set of zip codes, can you solve this for me? I have to wonder if they would be willing to help us.
So you haven't yet had that conversation about would you be willing to do that? Is that a fair statement?
I have not, and I think Aaron has far more leverage bringing them to the table than I do.
He does. He does.
Now, we have, Eric is in the room here, and he had a comment. Eric worked on telehealth for a little while, did you not? Some of the issues that were associated there with
With AZ3D, no. But the reality of getting access to change a fee schedule